it's Dr. Jenn Kennedy. I'm a sexologist and couples therapist. The Pleasure Project podcast is about sex and relationships. So this includes discussions on desire, dysfunction, dissatisfaction, exploration of all things sex related. So sometimes I'll do toy reviews and we'll look at trends, and sometimes I'll also enlist other experts. We'll increase your insight and enhance your pleasure. So tune in. Hi, so welcome back. In this episode, I sit down with Dr. Kelly Casperson. She is a urologist and she is also a speaker and advocate. She knows a lot about menopause. We talk about all things in that department. So we're looking at hormone replacement therapy and the issues related to that. We're looking at lubrication. How does it work? When does it happen? When does it fail? When do we need something else? We talk about the clitoris, sort of the shape and the function, and we talk about couples dynamics and the hesitancy people have to go see a sex therapist or to see a urologist or all the care providers in that domain. So we're just kind of like meandering. It's a really informative, casual conversation. So I encourage you to tune in. All right. So welcome back. My guest today is Kelly Casperson. Dr. Kelly is a board-certified urologic surgeon, renowned public speaker, sex educator, and host of the podcast, You Are Not Broken. Dedicated to empowering women, Dr. Kelly blends humor, candor, and science to demystify sexual health, intimacy, and midlife wellness. Through her podcast and online courses, she tackles myths about desire and normalizes conversations around healthy, fulfilling sex. In addition to the podcast, Dr. Kelly has developed online courses, a book, and a membership that empowers women by teaching them the fundamentals of their anatomy, physiology, and sexual function. Her approach helps women dismantle limiting beliefs and live their best love lives. Her work provides essential education on hormones and midlife health. So welcome.
Thanks for having me.
Yeah, so I loved your book. I will start out by saying that it really touched on so many things. You included so much research that I've read in different ways in different places, and you like neatly tucked it into what you were talking about, gave some data and then really made it very approachable. So appreciated that. So let's start with just why did you choose urology? Like, how did that happen?
Well, the urologists are the coolest people in medical school. They're funny. You have to have a sense of humor to talk about and look at genitals all day. And there's a lot of instant gratification that happens in urology, right? So like you have a kidney stone, it's gone. You have a bladder cancer, it's gone. You can't pee, now you can. Your penis is soft, now it's hard. Right. So there's like so much instant gratification that I was like, that's what I want to do. I want to know that because I showed up today, something happened. Yeah. Because so much of medicine's like, well, try to stop smoking cigarettes and maybe we'll adjust your medication dose. And I was like, it's not enough for me.
And then what are some of the most common issues that patients come to you?
Yeah, well, like I'm one of 10% of the female urologists in America. 90% are men, right? Mm-hmm. So my practice skews heavily towards female because there's simply not enough of us. And women do care to be treated by people who understand their issues. Recurrent urinary tract infections, bladder leakage, vaginal prolapse, kidney stones, can't pee too much. That's the gamut. And then, kidney cancers, prostate cancers, bladder cancers, testicular cancers, all the genital urinary systems, sexual dysfunction,
Do you
all
find
genders.
That women prefer to work with a female practitioner when possible?
Yeah, I mean, the ones that see me, the ones that prefer men don't come see me. So I don't know. I don't know about them.
Well, and do men come to you as frequently? Yeah.
Mm-hmm. Yeah. Oh, a lot of men are just like, I just feel like I can talk to you. I'm not embarrassed.
Yeah. I kind of get that too, that some men don't want to see a man when it's around their genitals or personal information in that department. They actually prefer to see a woman. So kind of interesting. And then in terms of like, I know what comes into the room with sex therapy specifically, but what do you find in terms of cultural taboos that tend to walk in the door oftentimes with people?
You're supposed to have an orgasm by putting something in your vagina. You're supposed to always want sex. The penis is supposed to always be hard. If it's not hard, that means he's having an affair or he doesn't find you attractive. Arousal should just happen. Another big myth is that like your sex life goes away after menopause. Young women shouldn't have to use lube. Those are my myths off the top of my head.
Mm-hmm. Yeah, because all of those definitely, I think many people are carrying around, and those come in pretty frequently across the board. Yeah. And medicine's sort of a different avenue, because when something changes from previous functioning, or it hurts, or, something's not working about it in terms of like leakage or a UTI or that type of thing, they're coming to the doctor to fix it. And they want sort of a neat way to have that done. Right. And yet many of these things are also lifestyle focused,
the
or
big one
influenced.
The big one's erectile dysfunction, which, let's be honest, clitoris is a penis. So there's clitoral dysfunction too. It's just way understudied. But the lifestyle that goes with erections that don't cooperate, it's alcohol, overweight, physical inactivity, high lipids, high blood pressure, side effects from antidepressants, side effects from high blood pressure medications, poorly controlled diabetes, anxiety, depression, right? So it's like all of that, smoking, all of that affects the function of the genitals, right? And so usually, they come in and they're like, I need to get hard. And you're like, dude,
let's look at the bigger picture.
Yeah, you got 8 things working against you right now. It's we'll try, but
yeah,
your lifestyle does matter.
Well, and getting engagement in terms of, I find that consistently people underreport when they're doing lifestyle behaviors that aren't in service of what they're trying to do. Like, for example, alcohol consumption is always underreported. I also find it interesting when couples come in, I have them do an intake. And oftentimes one of the questions I ask on there is frequency of sex in the previous month. And the same couple will report different numbers. And I'm like, usually the man reports low and the woman reports high. If you're going to look at them side by side. So
yeah.
Part of it's how do you define sex? But I think typically just the perception is also a factor.
Oh, so I think that's the other myth, that there's a right number of times to have sex.
Yeah.
Everybody wants quantity, not quality. Like, they want quantity more than they're like, but how is it? And they're like,
well, and that was one of the things that I like so much of what you said in the book. And Emily Nagoski is also starting to really talk about pleasure is the measure, right? That idea of like, let's go for quality. Let's go for actually having a really good time and feeling good, rather than getting it as fast and as frequently as possible.
Medicine's a low bar, right? We're like, is your penis hard and is your vagina wet? And do you not have pain when you put something in your vagina? Like, that's a low bar. That's what sex is.
Especially for women.
Yeah.
Yeah. Because that penetrative sex isn't oftentimes all that pleasing for women.
Yeah. Oh, that's another myth. We'll just keep going with myths as they pop into my head. Another myth is that my vagina is just to have sex with. So many older women, like, they don't even want to use vaginal estrogen to prevent urinary tract infections, to help with bladder leakage. Like, I'll be like, hey, vaginal estrogen decreases UTIs by 50%. And they'll look at me and they'll be like, my husband died 4 years ago. And I'll be like, how's that? I'm sorry, but how's that relevant to this conversation? Like, they really think their body part is for somebody else. And to me, that's disturbing to me every time I hear it.
That number that you just quoted too, like, I read that in the book, and I was like interested in that conversation, because lube is one thing, right? The people coming in, I don't see a lot of 20s coming in for sex therapy, but it starts to come in around 30s when they're having issues around childbirth and parenting and all that stuff. But really it starts more around 40s, mid 40s, where they're having sometimes more challenges with lubrication. But also the internal estrogen as a conversation, that has just started happening. More in my friend group. But
welcome to perimenopause, my friend.
Yeah. Hello, I'm 51. Squarely there.
Yeah. Yeah, that's the other myth, that menopause is just hot flashes, and then when hot flashes go away, menopause is done. That's the big myth. People have no idea that menopause means a profound absence of hormones. And that's testosterone, progesterone, estrogen are our commercially available ones. But one might argue that's the tip of the iceberg. And so people, if you think it's just a hot flash, you're not going to connect what's going on in your pelvis and your pain with sex and your lack of orgasm and your arousal issues. You're not going to connect any of that to hormone changes, which is you are going from hormones that are higher than what a man has for estrogen to a hormone that is lower than what men, my couples in their heterosexual couples in the 50s, I'll use him as an example in the room. I'll be like, he has more estrogen in his body than you do right now. And it really hits home to people. Like, I'm not talking lower than your 20s. I'm talking absent, below what a man has. Because, and again, there's the other myth that estrogen's for women and testosterone's for men. It's like, no, we're not gendered like that in regards to hormone
Well, and there was the whole hesitancy because, again, I have friends who are edging around 60 and none of them did HRT because they were so afraid of it. Yep. And I've been taking it for 3 years now, and I say, yay, I can sleep through the night as a result, but they didn't take it. And so they really suffered through. And also they haven't taken any internal and, they're suffering.
Yeah. I mean, here's the deal. The deal is like, everybody's like, oh, we're just making this an episode about myths. But people are like, why do ovaries, this is the question people ask, why do ovaries run out before our lifespan does? And I'm like, well, 2 things. Number 1, lots of things run out before our lifespan does. We fix our teeth, we fix our eyes, we fix our hearing, we fix our hips. We fix a lot of things. We just don't fix the ovaries that decline, right? So there's the one bias, is that only ovaries decline before you're dead? No, lots of things do, right? And then number 2 is people don't understand that 100 years ago, average life expectancy was 51. Like, this is it, sister, you're done. Right. But clean water, antibiotics, trauma care, cancer care, nice, safe supply to food, right? Like, we truly are living longer than we've ever lived. And people don't, they don't realize that you weren't alive 100 years ago. You don't know that, right? Yeah. The richest of the richest, the aristocrats, what's it called? The wealthiest of men in England in the 1400s lived to be 40, 42. Right. And that was the men who didn't die in childbirth. So
we're dealing with all whole new.
So because I think people they get kind of entitled. They're like, I don't want to have to put something in my vagina. I don't have to put on a patch. It's like, I don't want to put on a seatbelt when I drive a car. But listen, right? Like, it's preventing some bad stuff from happening, right? And it's like, you really have to work on this mind shift of like, stop being entitled to an easy functioning body until you're 84. And I think it's Gen X is seeing their parents and they're like, I think we should focus on prevention and preservation a lot more, because once you're 84 and you broke your hip, it's too late to start hormones. It's not going to help you anymore, right? Yeah. Hormones prevent, hormones don't treat. So that's my soapbox for being like, listen, people have got to get their mindset straight about this, because they think they're entitled to a fully functioning body when we like replace and protect everything else.
I also think though, for so many women, it was fear, right? Because of the kind of misreading of that data and that study.
Sure. And but so we know better now. So update your.
And the current guidelines are what? With specifically
current guidelines
HRT?
Are for the average person, the benefit outweighs the risk.
And so they should be taking it at what point? When they start showing perimenopausal signs?
Yeah, when you have symptoms. That's another myth, that you have to wait till your periods are done to start hormones. That's not true. There's nothing magical about a last period, my friend. Nothing magical about it.
Yeah. Okay. And then in terms of the internal estrogen, when should women start taking that?
Yeah. So just to clarify for your listeners, by internal estrogen, you mean vaginal estrogen?
Yes.
Yeah. Because estrogen goes in your mouth too, and that's internal.
Oh, okay. Yeah, that's true. That makes sense.
Okay. So we call it low dose or pelvic. If you're on Instagram, it's pelvic because Instagram doesn't like body parts.
It's true.
Or vaginal estrogen. So just so people know, that's low dose. It doesn't even increase your blood levels of estradiol. It's literally skincare. A lot of us, sex experts, hormone experts say it's preventative medicine. If 50 to 80% of women are going to experience genital urinary syndrome of menopause, 50 to 80%, it's probably higher than the amount of women who are going to experience hot flashes. So if it's that high, why are we waiting for 50 to 80% of women to suffer? Yeah. If we can just say, hey, listen, maybe it's fine now, but you're 55 and you want to keep things functioning, why don't you start some low-dose vaginal estrogen?
Now, also, there's different ways to bring that into the system, right? I know there's suppositories. There's just like, I've had a gynecologist say, just put this on your clitoris. Like, what's the protocol? And
so these are prescriptions. In America, it is a prescription. Over the counter in several other countries, that's how safe it is. But the cheapest is a cream. And I like the cream because you can put the cream on really for a lot of people, it's that 6 o'clock entrance to the vulva that becomes very dry, pulley, and painful with sex. That's like the notorious ouchiness. So you can actually put it on the skin that's getting dry and thin because it's a cream. Preserve your labia minora. Nobody knows that their labia minora goes away when their estrogen drops. You want to preserve your labia minora, get some hormone cream on there, and then clitoris to keep blood flow, to keep phimosis at bay. Phimosis is when the clitoral hood attaches to the clitoral head. It can become tight, painful, make orgasms more challenging. So we all have cream biases because we want the genital structures to get it as much as inside the vagina. You have to get it in the vagina in order for it to help the bladder with urgency, frequency, getting up at night to pee, recurrent urinary tract infections. Vaginal estrogen promotes a healthy microbiome in the vagina, and lactobacillus makes it acidic, which is why you don't get the bugs from the poop going up to the bladder. And you lose that microbiome when you lose your estrogen, you lose your lactobacillus, you get way more urinary tract infections.
Is that why? Because I know that has been a big correlative. That,
Yep.
And it seems like once it starts happening, I've heard of friends and clients that have reported that kind of more frequently.
Well, yeah. Well, you kill your whole microbiome with antibiotics too, right? So you get in this cycle of despair of like, you get a UTI, you take antibiotics, now your microbiome's even more hit, you're more susceptible to another UTI, and you're not solving the underlying why, which is low hormones. If you give, my friend did this amazing paper, if you give everybody on Medicare in America, so everybody 65 and older with a vagina, if you just mailed them vaginal estrogen for the year and they used it, you would save Medicare like $10 billion a year just in 50% reduction in UTIs.
Yeah, I remember that actually being a thing in terms of my grandma when she was in her 80s and stuff. She was getting UTIs, and that's okay. So that makes more sense.
And for people who have that grandma, you can start vaginal estrogen at any age. We start 90-year-olds on vaginal estrogen.
Right, because again, the numbers are super low, so it's not affecting your overall.
Yeah,
okay.
Totally. So vaginal cream, vaginal suppositories, like little pills. There's a ring, which is nice. It's plug and play. A little more expensive. And also the things that just go in the vagina. Again, you can't put the skincare on the vulva. But that's why I like cream. It's cheap, and you can target the vulva with it.
So, okay, let's talk about the pelvis in general. The pelvic floor work, I feel like, is another thing that never got mentioned in my life in my 20s or 30s at all. Like, I was referred to a pelvic floor practitioner, I don't know, probably 10 years ago. And I was like, what? This person's going to do internal work? What? Like, how's that going to go?
Yeah.
And I mean, it's a referral I make quite frequently now because they're in their own lane and they know stuff that others don't know. And it's really incredibly helpful.
Yeah. I mean, I always talk about my 3-legged stool for pain with sex is sex therapist, because you got to break the pain cycle. You got to break the fear. You got to rediscover pleasure. You got to do all of that cognitive stuff that goes when you set up pain.
Yeah.
Pelvic floor PT, because muscles get tight to protect areas that are painful, right? So you got to undo the tightness. Sometimes there's hip issues, low back issues, and then me for the hormones. And to, get a good pelvic exam in to see if there's something else going on. But I'm like, if you're missing one of those 3 things, the stool falls over. You're not going to get as much better.
I actually, at one point, was having pain, and I went to a primary care who was a concierge, and he told me it was anxiety. And I was like, I don't think it is anxiety.
Nice.
And he prescribed me, anxiety medicine. And I was like, this isn't it. So I pushed on him, and he sent me then to a gynecologist, my gynecologist. And she said, no, I'm going to send you to pelvic floor, physical therapy. Okay, great. Because he wanted to make sure it wasn't endometriosis or fibroids or whatever. And then I went to the pelvic floor person, and she said, it's your psoas. It was so obvious, which is actually what my massage person said before I started this whole journey, and I didn't believe him because he's not a doctor. And then at the end, I was like, he was right the whole time. It was my psoas.
PTs and massage therapists are much better with muscles than MD physicians are. We just didn't get the training.
Yeah.
There's no doctor of muscles.
Yeah.
Except in the MD DO world.
Yeah. Well, and pelvic floor PTs are not, they're PTs that then did a specialty in pelvic floor, right? So not every PT knows pelvic floor at all.
Right. Yeah, I always tell my women, I'm like, don't go to some shoulder guy. He won't be stoked. He won't be stoked about your leakage and your pain with sex. He wants to work on shoulders.
Yeah. And also, I've talked to a pelvic floor person on here before, but just the idea that sometimes the leakage or sometimes the pain can mean you're too tight, right? It's not just do more Kegels as a across the board, which is where a lot of women go.
Yeah. Yeah. The people are like, I do Kegels. And I'm like, I don't care, man. Like, if Kegels worked, we'd all be out of jobs. Like, they don't work for the majority of people. And like PT, they didn't get like doctorate degrees in Kegels. Like, there's so much more. And until you go, you don't have any idea.
And I think a lot of people hesitate to go because the internal work feels really intrusive. But I mean, pregnancy, gosh, women have all kinds of
right.
intrusion.
But that's for another person, right? You're checking on my baby. Now this is me. Like there is I think there's a difference in mindset with that. But yeah, I mean, to me, I'm like, listen, tell your physical therapist that you need to go slow, that you want to understand the why, you know, maybe that you've had past trauma. Let them know that, because for them, they're going to go like, I want to get the job done. I want to find the solution. Like they're a lot more comfortable at moving faster because you're the 10th person they've seen today.
Right.
Right. Like you have to remind them this is your first time having this done.
Yeah.
And good PTs are going to totally listen and totally respect that and go at your speed.
Yeah. Okay. Let's talk about fluids, because I also feel like that's a really misunderstood area. The younger couples especially feel very hesitant to use lube. The older couples too, though, I would say over 45, right? There's this whole history of like, she should, if she's wet, it means she wants it. If she's not wet, something's wrong, you know? So,
I mean, all of our problems come from the fact that we don't have a good sex ed.
Yes.
You know? And that's
so
all
true.
This is. It's like, do you see people put lube on Hollywood films?
Never.
No. In music, do they like, and then I put the lube on, right? Like we literally don't get taught that that's normal. And it just makes everything better. Like there's data on this. Like you're like 25% more likely to have an orgasm when you use lube. Like, and I'm like, why are you making all of the work on the vagina? Like the penis doesn't lube itself. Like the clitoris doesn't lube itself.
So
right?
Can you explain, like, what is the process for lubrication in the body? Like, how does it happen?
Increased blood flow to the pelvic world. Brain's like arousal. Pelvis says arousal. Increased blood pressure, basically. That forces exudate or transudate across the vaginal walls. So basically they're pushing, it's like your plasma, right? You're pushing it through the vaginal wall, and it's basically vagina sweat.
And it's the idea too that the body understands there's sexually relevant things beginning.
Yeah.
So arousal means the body is responding. It doesn't mean there's desire necessarily.
And they're not always related. You know, like you can have desire and not be aroused, or be wet and not want sex. They're completely separate things.
Yeah.
But then, you know, that's why I always joke with women. It's like, if you're not an 8, don't penetrate. Because I think a lot of pain comes from the fact that people think sex is just putting something in the vagina. So they just put something in there. And the body's like, is this a tampon? Like, I didn't get the memo. You didn't tell me what this was supposed to feel like. Like, give the pelvis the memo, what the plan is. And it's going to be a lot easier to have pleasure if you're turned on before something goes in the vagina.
Hi, hope you're enjoying the episode. Wanted to reach out to you. This is Dr. Jenn, and say, hey, if you would like to deepen your own experience with this, there's a couple options. If you head over to pleasureproject.us, you will see several things. There's lots of articles. There are also merchandise items that you can buy if you're feeling enthusiastic. You want a tote bag. We've also got fun cookie cutters. You could also join the wait list for an upcoming Pleasure Circle, which is a small group intensive that I lead. Would love to have you. If you want to know more, check out pleasureproject.us. And if it's a longer session of penetrative sex, the lubrication is going to run out. That's normal.
Yeah.
Totally. Right. So just because you've got that initial pass doesn't mean that it's going to stay. And so there's no harm, no foul in having it nearby and reapplying.
Yeah, like just lube every time. We just normalize it. You know, I had a 20, you know, we all think like the younger generation's doing so much better than us because they've got access to all this info. And in 1 week, I had like 2 young women in their early 20s come in for pain with sex. And I'm like, well, how does sex start for you? She's like, I just put the penis in the vagina. And my boyfriend told me I'm not supposed to use lube. And I'm like, he doesn't know. He's effing 20, right? Like, let's not take advice from the amateur over here. So, yeah, well, they're not doing any better than us. They aren't getting good sex ed either.
Yeah. Well, and is he able to masturbate for that long without any sort of...
Yeah, right. That's what I'm saying. The penis doesn't lubricate itself.
That's right. So, you know, friction hurts everybody. Okay, so then since we're down there, let's talk about the clitoris and the full shape and function, I guess.
So the clitoris is basically the penis, right? It's the organ of pleasure. In females, we only see the tip of the iceberg. We see the glands. And if you are savvy enough to go right above the glands and kind of rub back and forth, you can feel the clitoral body. And then we have the bulbs of the clitoris that wrap around the vagina. So that's why vagina fullness, vagina stretching, friction in the vagina feels good, is because you're arousing the clitoral bulbs. We have erectile tissue throughout our pelvis. We just never got taught that. We just think penises get erect, but female pelvises also get erect, and you have to arouse it. So it's completely neglected.
And signs of arousal
school.
in women are going to include what?
Feeling a fullness, feeling heat, feeling, if you're actually going to stare and look at things, you're going to see that the labia will get engorged. The vagina actually will lengthen and tip back, getting the cervix out of the way. That's not something you can easily see, but it explains to women a lot why you need to be aroused before you put something in the vagina. I see this a lot of like size mismatch, call it that, right? So like a smaller woman paired with a larger man, and then she thinks she's the problem when she has pain. And I'm like, listen, erect penis size is not what unaroused vagina length is. And if you have to be aroused to get the vagina long enough, and even then, you might be small on the smaller end, right? And women, you don't know that because you don't get sex ed. And so it's like, they just think they're the problem. And I'm like, no. There's
well,
things
and I've seen
do.
those little kind of inner tube things that you can put on.
The Onut.
Yeah, that provide a little buffer.
Yeah.
For length. What about girth? Like, is girth really a problem?
Probably for some people.
Yeah.
We're all unique snowflakes.
Yeah. I feel like to the idea that, if you've got enough foreplay happening, if you've got some preparatory and some communication happening, then most of the time this can get sorted out. But it's the quickness, the urgency that ends up taking people to a place where pain is happening, and then it's just trying to get it over with. And then
and you see it. I mean, this is your not horrible combo. This is your common combo as people get older. Is you have a woman who tends towards dryness now because of menopause changes, or she's already had some atrophy. Maybe she's untreated, right? So you've got a woman that tends towards dryness. You've got a man that tends towards erectile dysfunction, because remember, age 40% are already suffering from erectile dysfunction, right?
Yeah.
So he needs more stimulation and longer stimulation in order for him to orgasm. So he's taking longer in a drier vagina.
Right.
Guess who's going to stop having sex pretty soon? Yeah. That couple.
Yeah.
Right. And it's like, it's not just her that's aging and changing. It's like she needs estrogen. They need lube, but he also needs to address his erectile dysfunction or do some pleasure outside of the vagina, because now he requires longer latency to have an orgasm. And it becomes painful after a while, even for a very well lubricated vagina. It's like, come on.
Yeah. Well, and sometimes I hear too, it's like, well, when we stop to re-lube up, it breaks the mode, and then his erection goes and it's game over.
Well, lube up beforehand.
Or
lube up during.
Or
where's their lack of creativity, people?
Come on. Or just stay with it, and let's also think about the fact that sex can happen in a lot of ways outside of penetration.
100%. Yeah, I always worry, like when people say that, like there's plenty of people who put lube on and that does not stress them out. Right. And it's like, do you have a stress component? Do you have an anxiety component to that? That's more likely to make the penis soft.
Well, and also just with self-stimulation. I mean, women can orgasm so much faster when they're by themselves. Yeah. Right. So it's not.
They take as long to masturbate as men do, where all of our bodies are very similar. Right. You put it. I mean, the famous bisexual study. Come on, we got to talk about it. You put a penis in the room, her rate of orgasm goes down.
Yeah. Well, I remember looking at when I was doing my dissertation, it was specifically on lesbian sex particulars and how much higher the satisfaction was for women in relationships with women sexually, in part because sometimes they don't need to have penetrative sex. The sex is less frequent, but more satisfying typically.
Yeah.
So,
yeah. And I mean, how curious that we, are even talking about that sex should not take long. Right. Because it's like many people will be like, no, longer is better, and we're like, it's this most amazing, pleasurable thing. And we're like, can this be done quicker, please?
Right. It's like the journey is the destination.
Yeah. This is a great meal. I wish it would end.
Yeah. Yeah, that's true. Right. It's like, normally
an amazing movie.
We love things. We want to savor it. And
it's an amazing movie. Why isn't it shorter? Yeah. Like we don't do that with other things.
Yeah. And I see a lot of couples that are in longer term relationships. And so they're returning to the same configuration. They oftentimes click into the same dynamic. And then it just goes for another round of that cycle. So trying to get them to do something different, again, it is that come on, you're here.
That's
you're
where
here
the sex therapist. I know. I was talking to a sex therapist friend the other day, and she was talking about like her rates, how much money she charged, and stuff like that. And I was like, average divorce results in 50% of your wealth loss. Correct? And she's like, yeah, in most states, some states are different, and like, blah blah blah. But on average, you could assume that you're going to lose 50% of your net worth with a divorce. And I'm like, okay. So if most divorces or a large amount of them are because of lack of intimacy, how much do you think you're worth now? And she was like, noted. Thank you.
It's this thing too, where couples that have been together a long time, like they have trust, they have admiration, affection. They just, for the most part, I don't find that they had great sex and then now they don't, especially if they're older. I think most of the time they never had great sex. They had okay sex, but there wasn't a lot of communication. There certainly wasn't a lot of focus on her pleasure. Do you know women get to around 50, they're empty nesting. They're like, do I want to re-engage, now that we're sort of looking at our coupleship again? I don't want to do it like we did it before.
Yeah, I agree. And I think, another myth is that desire is, thank Freud for this, but that desire is appetitive, which is a fun word, but like an appetite or like hunger, thirst, sleep, right? Like the less you have it, the more you want it. That's not how desire works for a lot of people. Like you don't have it for 2 weeks and you're like, take it or leave it. I don't care. I think I forgot how to be sexual at this point, but I'm not going to die. Right. And so like you pair that with like the meal was never that good in the first place. Yeah. Like she is not going to go out and pursue this, my friend. Not with you, because you've had a crappy grilled cheese sandwich for 30 years.
Yeah.
But I also think a lot for fearing of picking on people, but it's really like helping people see why they're stuck is like the couple will be like, they're just in their misery together against the sex therapist. We're like, well, it's just bad and it's just going to be bad. And like the sex therapist is like, what about this? What about this? What if you could experience pleasure in another way? And they're like, nah, we just want it to be how it used to be, but now it's not like that and it's bad. Like they get stuck in like a mutual badness.
Sometimes too, especially with heterosexual couples, I feel like, the man in particular sees only penetrative sex as qualifying, right? The rest of it's all kind of like, it's not really there.
Yeah. Help me out with this because I'm on a hunt. First of all, that's how they're socialized, right? That's what sex is. If you like pleasure in any other way, that might be very threatening to your heterosexuality. Right. So like it's a very big ask to ask a man to think of pleasure in another way, first of all, in my opinion. But second of all, is like, where's the book on how to have sex with a soft penis?
Right.
Where's
stuffing?
That book?
Called Stuffing.
But where's the book?
Right. People are horrified when I even mention that it's possible.
Well, I know, but it's like,
right?
I've asked 6 sex therapists and it's half
it still
a dozen.
Has sensation, right?
Yeah. But I'm like, where's the book? Right? Here we are. Here's all the sex therapists being like, it's okay, have sex with a soft penis. And I'm like, but you're not giving them the how. Like to my knowledge, there's no book. And then people say, Kelly, you have to write the book. And I'm like, I think I'm qualified at this point. But like, they need a book, my friend, because unless you show them that it's possible.
Yeah, it's true. Well, and even just, sort of working around it. I mean, because erectile dysfunction definitely is in variations is coming in as I see clients that are older and older. And so how do we not get lost in shame and self-disgust and horrifying anxiety, right? Just like that paralyzing anxiety that comes up of anticipating that it's going to happen again. Sort of just look at it as a fun exchange between us that can feel sensual and pleasing. And I actually find though, okay, back to what you said before, the first point is that I kind of feel like I just lost what I was going to say. Is that menopause?
Yeah, it's totally menopause.
Shoot, it just happened. Where we went.
Oh, it
went away.
People need to see it. People need to see that it happens and you can recover.
Yeah.
Yeah, I mean, I
don't remember.
I think, that's not a small amount of men who say, my sex life got better after prostate cancer surgery. My sex life got better after erectile dysfunction. Not everybody says that, but the people who've taken the journey and figured it out and learned what else feels good, they're all like, I was just doing one thing my whole life because I didn't know there were other things on the menu. And now I'm like, this is even better. You know, and you hear that a couple of times, and then you're like, it's possible, it's legit. Has anybody written the book? I've met nobody who knows where the book is.
I was talking to a guy recently who is working with bladder cancer and having some erectile dysfunction, and he's had shrinkage, and he's kind of begrudging the whole thing. And I said, okay, let me ask you this. If we're going to play Let's Make a Deal, I said, would you rather have chronic lower back pain, or would you rather have a slightly smaller penis? And he's like, I'll take what I have. I said, that's what I thought, right? It's like, it's just, everybody's got stuff, you know?
Yeah,
it still works.
Again, I mean, I think everything,
still feels good.
My dissertation is all of our problems stem from the fact that we did not get a good sex ed. Like, we did not get adult sex ed. It's crappy. Nobody knows that penises get smaller as people age. No, because muscles atrophy. Nobody knows that, 40% of erectile dysfunction by age 40, 50 by 50, 60 by 60. Right? Like, people don't know that. So then you internalize it and you say, I'm the problem.
Yeah.
Instead of being like, this is how bodies body. You cannot expect a 64-year-old to function like an 18-year-old. It's just not realistic. Okay, now you have the education. What do we do about it?
Yeah. Okay, my thought came back.
Okay, good. I knew it would.
Which is the idea that oftentimes what I find that men in particular want when they say they want sex isn't necessarily sex. It isn't just the penetration and the orgasm, but actually it's touch needs. It's connection, because it's like I'm often asking, what is sex about for you? Like, what is the function? Because if their partner is sort of hesitating sex because it's painful or just not as of interest, then oftentimes I find that they pull back and don't give touch in general because they don't want to lead them on and have it go to something else where they're expected to have penetrative sex. So if we can sort of broaden it and just have them get some of their touch needs met, that oftentimes is really helpful. It serves some of that purpose, and maybe physical isn't, it's lower in priority a bit.
Yeah, I mean, I joke. It's like there's two people living in the same house. One person needs love to have sex, and one person has sex to feel love.
Yeah.
And they have no idea they're living together.
Yeah.
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 So you're like, that's a huge thing. It's like, hey, what's sex mean to you? And does your partner know what sex means to you? When the first time I asked my husband that, like 10 years in, I was like, whoa, I did not know that. Right.
Yeah.
And I think it lends so much more compassion because, again, stereotypically, the woman will say, he just needs sex. He just needs it, and really dismisses because they don't understand the why behind it. And I think understanding the why really brings in the compassion of like, I didn't know that that's what it means, because women will dismiss it as like just this physical need. Yeah. And it's like, yeah, but there's stuff underneath that. You guys just never had a conversation. And like, it's so easy to dismiss people when you don't understand.
Right. Like, how else can we get that need met?
Yep.
Or they might even be more inclined to meet the need if they understand where it's coming from, rather than just boiling it down to, he's horny all the time.
Well, yeah, because, she again, stereotypically will be like, I'm just being used, right? And nobody wants to feel that. Nobody should feel that.
Yeah.
And so, it just goes back to communication. But again, in sex, did you get a sex ed that said communication's important? Right? No.
I got the most basic sex ed. I lived in Idaho, and they gave us like this really janky, like, neutered version of it. And then I moved. And when I moved schools, I never got the more, robust version. So I was like 30 reading Our Bodies Ourselves. And I was like, I didn't know there were 3 holes. I was so confused about that third hole forever.
Did you go into sex therapy later in life?
Yes.
Yeah. Okay. I think a lot of people do. I think they get they get an education, they get some maturity, and then they like see this overwhelming need and or they're freaking fascinated by the whole topic. And then they kind of go into it. I don't know. I haven't met many, like, I went into sex therapy when I was 21.
Well, because having these conversations, they're nuanced. You kind of have to be really comfortable with very personal stuff. Also, for me, it was an outgrowth of couples work. I was seeing a lot of couples, and in not always, but oftentimes it veers into sex. And so many therapists are not prepared to talk about sex.
Is that crazy? It's like doctors,
it's so strange.
doctors aren't good talking about sex.
Yeah.
Right. And then my sex therapist friends are like, no, we're just therapists who are comfortable talking about sex. And I'm like, whoa.
With some more training, but still, like, I've done talks for primary care and for gynecologists. And I'm like, do you really need this? And then I realized, oh yeah, they do.
Oh,
they know the physical structure, but how to talk about it, how to bring it up, how to, the lifestyle side of it. Yeah.
Yeah. I mean, even just the like women orgasm with clitoral stimulation, right? Like putting something, the amount of women who are like, I just need to get his penis in my vagina. And then I'm like, that's really what, like, that statement stops me in my tracks. And I'm like, what are you getting out of this? Right? What are you getting out of it? I'm like, what do you want? And then like the second statement is when I'm like, what do you want? And the woman has no idea what she wants.
Yeah.
And I'm like, oh, that's where we're starting from, my friends. That's where the adults are starting from.
Yeah. Yeah. How do we actually pull out and look at the bigger goal here? And how are you, you're not just interviewing for the job here. You want to know if you want this job too, right? Stop trying to like,
dude, that's good.
Win. Jeez. Okay. So I know that you have, first of all, I love your book and we'll put a link of it. You have a podcast. Yep. You also are really active on Instagram. I've been watching a bunch of your videos. Thank you. I encourage anybody that has enjoyed this conversation to tune in and look at those. What is your community?
I mean, the coolest thing about my community, so it's a private Facebook group, so they get all the podcasts without the ads as soon as I do them. So like today they're getting a podcast about pathologic changes to the body with alcohol and low hormones, because I interviewed a pathologist and it was super cool. So anyways, they get podcast stuff. But we do a fitness accountability in the private membership, where we basically post like sweaty selfies to like, because for me, that was what got me to finally get into a consistent fitness. Is like, there's other women showing up who are going to show me that they worked out today. So I better freaking do this. Like, accountability to myself wasn't enough. And so that's really important to me.
So the community, who would be, I guess, a good member in your community?
Midlife women who are like feeling alone and feeling like, is there more than this? Why can't I work out? How do I advocate at the doctor's office? Is this normal? Sort of stuff like that. So I have a monthly membership. If you just go to the website, they can sign up. And they get the sex ed course for free in the monthly membership, which is sweet.
Yeah. So good stuff. And I feel like that is squarely, I went to a lecture yesterday with a local physician and it was on menopause and 400 women showed up for it.
Oh yeah. It's huge.
And I was like, see, this is important.
It's 50% of the nation.
Yeah.
It's insane. Like, change is happening. What's happening now with awareness and advocacy for men with menopause wasn't even happening 2 years ago.
Yeah.
So it's like, it's happening fast. Gen X is taking the lead. We don't want to go down. We don't want to go down like we're seeing everybody go down. And it's very exciting. Because
you're having like celebrities, Drew Barrymore, and that are talking openly about their menopause, and I'm like,
totally,
yeah, okay,
yeah. I mean, the celebrities, they work in an industry where your career's over, at a certain age, and so to be brave and to be like, hey, we're still here, and we want to empower everybody else to keep showing up is pretty freaking amazing.
So, anything else you want to mention that's coming up for you professionally?
Oh yeah, well, the Casperson Clinic. So.
What's that?
Private boutique clinic, minimum hour with me. Just healthcare that does not and cannot be delivered in the insurance-based model. So
and
I think
is that only for people living in your state, or can
they have to come?
Consults?
They have to come to Washington. So I have a license. I have a license in Washington, and I'm busy enough that I don't need any other ones.
Yeah,
so they can come to see me. But testosterone and challenging. I'm one of the top menopause experts in the nation now. So challenging cases like greater than 10 years post menopause. Can I be on hormones post breast cancer? What's the role of testosterone? All of those more challenging. All of those in and of themselves could be their own little boutique clinic, right?
Yeah.
But it's hard enough to self-advocate when you're straightforward. 52 and having hot flashes is hard enough, let alone all these other women who are like, what about me? Like, the entire generation of boomers who lost 20 years of access to hormones because of the misstated Women's Health Initiative. So I see tons of 72-year-olds, 74-year-olds, they're staring down the barrel at a hip fracture.
Yeah.
Like bones won't last decades without hormones. They just simply don't last. And it goes back to that, like, hey, if you want to live well, you got to preserve. You can't just fix it once you're 84.
I mean, I remember coming into this at 48 or so and thinking, I'm not going to take hormones. I don't want to do that. I don't want to take anything I don't need. And then the hot flashes at night, or the night sweats, you know, were just, I was like, I can't think, I can't function if I don't have enough rest. So that was sort of my mercy.
Yeah. No, it's crazy. I mean, you know, people don't understand. You know, our body health literacy is awful, right? Like there's 3 holes, for example, but it's like people don't understand because you can't see
that
ovaries.
one is kind of hidden though. It's hard to find.
They're all hidden. But yeah, like you can't see your ovaries shrinking, right? So it's like, it's literally something you kind of have to trust and believe and understand, because you won't see the effects of low hormones until they become cumulative, right? And I think more people in the Gen X are caring now of like, why are we waiting for osteopenia?
Yeah.
Why are we waiting for osteoporosis? Why are you waiting for dementia? You can't do anything once you have dementia.
Yeah.
It's like, listen, there's studies that say you live 3 years longer when you're on hormones. We have that data. There's data that says dementia decreases by 35%. There's data that says multiple sclerosis and Parkinson's decrease. Like you cut your heart disease by 30 to 50%. And it's like, once you understand that, you're like, what am I doing? Let alone, you know, divorces happen because of loss of intimacy. That's 50% of your wealth.
Right. Well, that'll hit your pocketbook.
That might, if sleep,
but
sleep doesn't
health
hit you.
And wellness, right? That feels like it is front and center, and it hopefully should be for men and women. But yeah,
everybody. Yeah. Well, I mean, to be very fair, men's hormones are undertreated too. Their access is better.
Yes.
But they're undertreated as well. I mean, the data is, I was just talking to a male testosterone expert this morning, and I'm like, is it true? Is it truly an accepted fact that 50% of overweight men have low testosterone? And he's like, oh yeah, no, that's POTUS. And I'm like, and low testosterone in men is associated with dementia, diabetes, all-cause mortality, cardiovascular disease, right? And so it's like, they're undertreated as well. So the medicine shifting to a prevention versus just treating you when you're broken, that's going to take a long time. But it's going to happen faster when people are advocates.
People tuning in and recognizing, right? Because, I mean, you'd think the onus would be on the doctor to say, hey, you're this age, you might want to think about this.
They're too busy. Doctors are too busy.
They're just, in and out. So
we're pulling people out of the stream, down the stream.
Yeah.
Right? You got to prevent them from falling in the first place.
Yeah. Well, thank you. This has been really
informative. Thanks for having me.
So helpful.
Super fun.
Yeah, I love your energy. I love, how you're just like no nonsense when you're talking about all this stuff. I think it's really empowering and it makes you approachable.
Yeah. Like you don't have to baby step around this stuff. It's just life.
Yeah.
Right. It's just life, people. We're adults. We're all adults.
That's right.
Here.